Good morning, everybody. My name is Morgan Carlock. I am the Clinical Quality Assurance Specialist for the North Carolina J.C. Burn Center. I'm very excited to share with you all today our research, a 10-year review of the geriatric burn population at a single burn center. The next slide, please. We do not have anything to disclose. Next slide, please. According to the 2020 U.S. Census, the 65 and over population increased 5 times more than the total United States population from 2010 to 2020. As of 2020, more than 16% of the U.S. population, or approximately 1 in 6 people, was age 65 or older. This proportion is only expected to increase as the baby boomer generation continues to age. As elderly patients often have increased frailty, reduced independence, and cognition changes, they are especially vulnerable after any trauma-related injury, including burns. Burn injuries in the elderly are associated with more severe injury, longer length of stay, and worse outcomes when compared to non-geriatric populations. In order to better care for this population, we sought to identify and describe trends in geriatric burn patients at our regional burn center. A retrospective analysis of adult burn patients admitted between 2015 and 2024 was performed. Patients were stratified by geriatric status. Patients with skin diseases, non-burn injuries, and pediatric patients were not included. Patient demographics, hospitalization data, and burn characteristics were obtained from the Institutional Burn Registry and electronic medical records. Demographic and clinical characteristics were compared between age groups using chi-square or Fisher's exact test and t-test or Wilcoxon rank sum test. Bivariate and multivariate linear and Poisson regression models were used to assess temporal trends and evaluate associations between calendar year and outcomes. Next slide, please. Geriatric patients accounted for a statistically significantly increasing share of adult burn center admissions. From 2015 to 2024, 15.4% of adult admissions were 65 years of age or older. Among these patients, males accounted for nearly 65% of the cohort. Flame burns were the most common mechanism of injury, causing 60% of admissions. Scald burns were the second most cause of burn injuries in the elderly, causing 28% of admissions. 6.1% of geriatric patients had an inhalation injury on admission and were significantly more likely to have one when compared to non-geriatric adults. The average total body surface area burn was 6.8%. Geriatric adults had an overall larger average TBSA than non-geriatric adults and also had larger areas of full thickness burns. Comorbidities were common in this population, with 86.5% of patients having at least one documented pre-existing condition. Intensive care unit admission was required for almost 29% of patients, with an average ICU length of stay of 13.2 days. Ventilated patients spent an average of 2.6 days on a ventilator. The average overall hospital length of stay was 13.7 days, with a mean of 4.3 hospital days for each percent TBSA burned. The in-hospital mortality rate was 8.8%. Just over 74% of geriatric patients were discharged directly home, and 12.2% were discharged to a care facility such as a long-term acute care, a skilled nursing facility, or a nursing home. As you can see, there has been a steady increase in the mean age of adult burn patients over the last 10 years. The mean age of adult burn patients increased from just over 44 years old in 2015 to 46.5 years old in 2024. This change was statistically significant, and each additional calendar year corresponded with an increase in median age of nearly half a year. A large majority of patients had at least one comorbidity, while nearly 2/3 had 2 or more. Hypertension was the most common, followed by diabetes and smoking. Neither the adjusted nor unadjusted regression model showed a significant change in the mean number of comorbidities among elderly patients. patients. The overall average TBSA for the 10-year period was 6.8%. There was a statistically significant increase in the average TBSA in geriatric patients, with the unadjusted model showing an average 0.26% increase in TBSA each calendar year. When adjusting for clinical and demographic characteristics such as age, sex, race, ethnicity, etiology, and comorbidities, each year is associated with a 0.35% increase in TBSA. Between 2015 and 2024, there was a great deal of variation in overall average length of stay. The linear regression model does show an overall slight decrease, but this change was not significant. There was also some fluctuation in the mean length of stay for every percent TBSA burn, and the model did show a slight overall decrease. However, this decrease was not statistically significant. While in-hospital mortality rates varied, there was an overall slight decrease over the 10-year period. When adjusting for covariates such as age, race, ethnicity, TBSA, ventilator use, and comorbidities, there was no significant change in mortality rate over time. There was a statistically significant increase in the proportion of geriatric patients who were discharged directly home. This includes patients who are discharged home with or without home health services. In 2015, 64% of geriatric burn patients discharged directly home. This increased to almost 80% in 2024 and has consistently remained above 70% since 2017. There was no statistically significant change in other discharge dispositions, such as discharges to care facilities. However, there was an overall non-significant decrease from 21% in 2015 to 11% in 2024. Despite statistically significant increases in age, TBSA, and proportion of geriatric patients admitted, there have been no significant changes in mortality, length of stay, or discharges to care facilities, and there has even been a significant increase in the proportion of patients discharged home. As the population ages, burn injuries among the elderly are expected to increase. Our burn center has already seen a significant increase in geriatric burn admissions. The elderly have an increased risk of all-cause mortality at baseline and often present with comorbid conditions that further complicate their burn care, from resuscitation through surgery to discharge and rehab. The need for age-appropriate care in this population is essential to optimize their treatment and recovery. By identifying and understanding trends in geriatric burn injuries, we are better equipped to prevent and treat this vulnerable population. Thank you.
Do we have a microphone for audience members? Okay.
Yes. It's called a catch box, guys. You
All
toss it around the room.
Dr. Feldman, go ahead.
Seriously. Just talking to the box.
Dr. Feldman, you're up.
Okay.
Speaking of the box, Dr. Feldman,
Yes, sir.
speaking of the
I've never
box.
held a catch box. I'm getting old because I don't know what this is. Great presentation. Loved it. It's a wonderful topic. I thought it was interesting that things were getting better. And I wonder if this is an opportunity for you to look at frailty, to look at activities of daily living. Age is just a number. If you come in robust, you're going to be more robust when you're done. So I think somewhere where you could focus your efforts is tracking activities of daily living and looking at that over time and where you started and where you end up. Great presentation.
Yeah, that's a great point, Dr. Feldman. So what I want to challenge the authors, and really everybody in this room, is to use this data, what we're seeing in our burn centers, to piggyback off some of the literature that's already out there. The UC Davis group, Katie Romanowski, wrote a paper about 10 years ago doing some pretty sophisticated regression analysis looking at frailty as predictors of outcomes. We've got the Burn Frailty Index. They're useful tools, but none of these are magic bullets that really allow us to, hit the nail on the head. Patient X comes in, they've got characteristics A, B, C, they're going to have a bad outcome. So how, now that we've got more sophisticated data through BCQP, how can we all work together as a group to figure this complex problem out that's only going to get worse? Go ahead, sir.
Hey, Michael Scher from Asheville, but if this is missing later, it's in my suitcase. So I'm just going to piggyback off of that. And my specific question is, did you look at hospice? I mean, what did your hospice referrals do over time? And in that hospice group, how many of those referrals do you think were because of the severity of the burn versus pre-existing frailty and needs to actually go to hospice before they even got burned? Did you look at that at all?
We did not look specifically at hospice, but I love that idea, and that'd be an excellent thing to look into for a future project.
Hello, Howard Smith from Orlando. Great talk. What I saw was that everyone was being discharged mostly to home, but to skilled nursing facilities and long-term care. What about rehab, inpatient rehab? Because I thought that would be extremely important for the elderly patient population.
It was lumped in with the others, as it was such a small percent of the group. The statisticians weren't able to pull any significant analysis from that small number. So.
When I look around the room, I see several geriatric burn surgeons who are normally very vocal, but they're remarkably quiet. Any of you guys care to opine? I won't name any names. Dr. Wong. Okay, thank you so much for the great presentation and discussion.